and more complicated. 2005, when I was chair of surgery here at Downstate, Ronnie Rosenthal, who is a graduate of our residency program as well, who was at Yale, created the task force of geriatric surgery under the lead of Jim Thompson, who was a wonderful GI surgeon at University of Texas at Galveston and was a proponent of the geriatric patient. And really, because of this task force, today we have a very comprehensive group of projects from the American College of Surgeons which address the geriatric patient. So we start off easy. Let's just deal with getting how do you change culture? So the first thing is education. So we have the American College of Surgeons Clinical Congress, which is every year, and we have the American College of Surgeons NSQIP, which is the database of safety from the American College of Surgeons. And about over 600 hospitals in the United States are part of NSQIP. So what we did was we used the power of the Clinical Congress for education programs, which we'll show. And we use the power of NSQIP to develop geriatric variables, which pushed the geriatric quality program called the Coalition for Quality in Geriatric Surgery, where we created a framework to improve the quality of geriatric surgery. And only about 5 years ago did it launch, or 6 years ago now, it launched the Geriatric Surgery Verification Programs, which is now really taking place in a number of hospitals in the United States. And it's been very gratifying to watch this. So how do you start the educational program? Well, you develop a geriatric panel at the American College of Surgeons. And I was the one who led this in the early 2000s. This is me at one of our panels. This is Sophie Fu, who's one of our residents, who is now a breast surgeon on Long Island. And we went from 2007 and 2008 to really 6 or 7 presentations a year and over 50 abstracts submitted every year to the surgical forum. And that's where it started. And it was the surgical forum is for residents and junior faculty, and we really ultimately partnered with the Palliative Care Committee of the American College of Surgeons to increase awareness and education. And then we had 2 really, or 3 real, actually more. I ran 2, but there were probably 4 or 5 geriatric forums as the main panel sessions at the College of American College of Surgeons. And this was one of them called Frailty Indices as Indicators for Risk in Surgery of Geriatric Patient. These were the young leaders at the time. This is about 10 years ago. This is Tom Robinson from the University of Colorado, Emily Finlayson from the University of California, San Francisco, who really have been leaders in geriatric surgery. And in 2019, we had our another one, and this was Dori Segev, who is a transplant surgeon, but an expert in surgery of the frailty because transplant patients are usually frail. Ronnie Rosenthal is here. Rachel Kataru, who is a geriatric surgeon in Canada, and Zara Cooper, who is now really one of the lead surgeons in the United States on this topic. So this is how we change the culture with education. These sessions, although they were kind of common topics, they were packed with surgeons because everybody wanted to understand the new concepts in taking care of their elderly patients. NSQIP, which is the National Surgical Quality Improvement Program, is a product of the American College of Surgeons. It takes probably 200 variables, pre-op, intra-op, and post-op, and puts them into a database, and you get your risk scores and your stratification, how your patients in your hospital compares to other. So we were able to develop with Cliff Coe, who runs NSQIP. Cliff is the director, and he's a colorectal surgeon at UCLA, geriatric-specific variables. They tested them, and there was a voluntary participation in the beta test. They got 13,000 cases of geriatric patients in 2014. They developed preoperative risk factors, which ultimately included home support, cognition, surrogate patient cares, and history of falls. And then they compared these to postoperative outcomes, which included delirium, new mobility aids, and functional status. And these variables ultimately were changed and coalesced into functional variables. I mean, in the beginning, we just asked if the patient got delirium post-op, and nobody knew how to what it was, so we just said yes or no. And now there are actual criteria for what delirium is. And in 2020, the variables came out, and for patients over the age of 75 years. And like I said, it's been very gratifying to see this become almost a standard, not standard of care issue, but a very commonly used metric. So these were the metrics. Patient lives at home. These are the risk variables. Does the patient live at home? Was there a history of fall within 6 months? Is there a diagnosis of dementia? Not are they demented? Was there delirium post-op? And they defined delirium. Was the patient discharged home? Was the patient discharged home with ancillary services, which is kind of going to a rehab center? Functional health status on discharge, independent, partially dependent, totally dependent. So they actually created new indexes and new metrics for general surgeons to follow, which we simple people were able to understand and implement. We also have a number of initiatives in the surgical world of geriatric consultations. And this, I'll show something we started a few years ago. When I was at Hopkins, we developed the first geriatric surgery consult service because our hospital was next to a nursing home. And we had a couple hundred patients that we were able to follow. And it taught me how to look at patients in a different light because these were nursing home patients. This was a geriatric consultation service for trauma patients. And they determined that the best there's less functional decline after trauma in certain patients, and multidisciplinary services, which includes geriatricians, rehab, palliative care, niche nursing, and social workers, results in a less functional decline if it's implemented early. And this was an editorial about an article by Bilal Joseph from the University of Arizona, who's really been a proponent of geriatric surgery in trauma patients. And in most of my editorials, I always try to get a Bob Dylan quote, and "Gonna Change My Way of Thinking" was actually a really appropriate one for this one. What about regionalization? This article was an editorial about trauma regionalization, where the article showed that patients who went to a level 1 trauma center without a geriatric program had worse outcomes, actually, than patients who went to a level 2 or a lesser trauma center who saw more geriatric patients and had a geriatric center. So the question here was, do trauma patients, all of them, need to go to level 1s? The answer is not necessarily, because it's all based on the capability of the hospital taking care of the patient, not necessarily of the hospital trauma center designation. Because again, most traumas in elderly patients are falls, which are hip fractures and other fractures, and neurosurgical issues because of head strikes, as my residents call them, and especially if they're on anticoagulants like Plavix and others, and aspirin. About 15 years ago, I thought maybe the best idea was to make a geriatric surgery institute. This unfortunately costs money, so not everybody in hospital administration was interested, but certain hospitals have done this. You can have light and dark contrast pictures at the right level so patients can see it. Easy parking, put the parking spot outside the doctor's office, not 4 flights away and 6 hallways away. Make this chair strategically placed for rest. Cognitive, visually make it bright. Hearing for impaired, take that into consideration. Low background noise. Make sure patients have their glasses. Make sure they have hearing aids. And just make it easy for patients and their caregivers to get in and out of both the institute for outpatient and the unit for the hospital. Back then, not all the hospitals had railings along the hallway, and we had to make sure that for geriatric patients there were railings. Now, if you go to a hospital, many of the hallways have them anyway, so it's not as big of a deal. All right, this is the geriatric surgery verification program I spoke about. It was actually funded by the John Hartford Foundation, American Geriatric Society, American Society of Anesthesiology, Pharmacy, and Rehab Societies. And this is the Gray Book, which came out, which embedded NISQIP, which we talked about, TQIP, which is the Trauma Quality Verification Program, MBSQIP, which is metabolic surgery, which is bariatric quality improvement programs, and Strong for Surgery, which is another one. And again, once TQIP, once the geriatric surgery pilot program came out, the GSV, we did the same thing. We created a framework. The whole idea was to create a framework, and we started the whole thing with education at the Congress and research using NISQIP and the Geriatric Surgery Pilot Project. Again, it was launched in 2019. Now there are 18 hospitals which are certified. 7 are in the Kaiser system in Northern California, run by Anita Chu, who was one of our residents here in the mid-2000s, who is one of the lead surgeons in geriatrics in Kaiser in the northern part of California, something we should really be very proud of. Here are the components of a geriatric surgery service. Personnel, you need a director. It doesn't have to be a surgeon. Geriatricians work just as well, even anesthesiologists, somebody who has an interest. Data collection for the geriatric variables, frailty, delirium, morbidity, mortality. Committee oversight, making sure all the patients are reviewed. Education, really to kind of do some research. And the more you educate and you go over your patients, the more everybody learns. And this is Anita Chu and me at the last American College of Surgeons program. And she was telling me about this, and she is the director of geriatric surgery in the Walnut Creek and Antioch area and lead surgeon for Kaiser for geriatric surgery. And this is her program at work. She's now done, I think, 4 hospitals where you go and can stratify elective and urgent cases, triage them to the right anesthesiologist or geriatrician, get the senior surgical care, go to the OR, or go with non-operative management. And you go from phase 1, which is the general surgical, orthopedic, urology, vascular surgeries, to higher level if you need with neurosurgery, cardiac, and spine surgery and neurosurgery. And this is pretty much the same thing again. These are the CMS age-friendly hospitals. So the CMS is actually taking this as well. They're not related to the Geriatric Surgery Verification Program, but CMS this year has age-friendly hospital measures. And the GSV, the Geriatric Surgery Program, the NISQIP, geriatric variables, and your NISQIP reports are useful for this because it shows one is going to be able to show these 5 goals, which is eliciting patient healthcare goals, medication management, the Beers criteria again, frailty screening, and we have all the screening techniques available that we mentioned in the previous slide. Some of which are really complicated, some of which are relatively simple. Social vulnerability, how the patients are at home, and age-friendly leadership. And like I mentioned, Anita's doing a wonderful job leading the charge with these at multiple Kaiser hospitals. And these are the, 8 or 9 hospitals. 7 to 15 HCS verified hospitals are in the Kaiser, which is amazing. Switch gears a little bit towards the end. Palliative care. We're not going to talk much about it, but it is important. And the message is palliative care is something we need to recognize in surgery because not every patient needs an operation. Some patients can have palliative operations. And some patients, I tell my residents, it's okay to say no if you think the surgery will actually harm the patient or even hasten their demise. This is what I mentioned before. We had a general surgery consult service in a nursing home in 1996 where I was the lead surgeon for it was a couple hundred patients that we followed. And we found breast cancers in nursing home patients, vascular problems in nursing home patients, and we changed the way we treated them based on their condition and their goals of care. And this is almost 30 years ago. And I think it was a little it was a little ahead of its time, and I'm proud that people are starting to use these concepts now. This was an Emily Finlayson article from 2011 about surgery in major abdominal surgery in the nursing home patients, and these were patients who underwent cholecystectomy, duodenal ulcer surgery, colectomy, appendectomy. Most of these operations were emergencies, and this was a database review of Medicare patients from 1999 to 2006. I don't have the data from it. Basically showed that the mortality rates were pretty significant. And if you use the concept we talked about with palliative care, you can actually have good results and good patient satisfaction and family satisfaction at the end of this. Palliative care actually has an history. Of course, with me, it's all going to go back to surgery. And the first palliative care physician was this guy, Balfour Mont, who was a urologist in McGill University. And the first palliative care hospital program was run by a guy named Jack Zimmerman, who was at Church Hospital in Baltimore. He was an associate professor at Hopkins and showed in the 1950s stents. They called them substitutes, stents for esophageal cancer, trachs for thyroid cancer, which were unresectable, and he started the first hospice program. Interestingly, the Blalock-Taussig shunt, which was the Blue Baby operation, was originally considered a palliative operation. The good news is that the thing actually worked. And as you know, Dr. Blalock and his technician, Vivian Thomas, who is an African-American technician, actually did the first one successfully at Hopkins. What about surgery at the end of life? And this is a topic which isn't we experience a lot of, but we don't talk about it much. And this was an interesting article from the American College of Surgeons newsletter talking about a Lancet article in 2011 about clinicians should consider the patient's goal when determining the need for surgery at the end of life. And it makes a lot of sense, but we don't do it very well. 30% of elderly patients will have a procedure in the last year of life. That's a lot. And that's what the striking thing was from that article. And the inference was, or the implication was, that we are doing too many surgeries at the end of life. But if you actually look at the paper, it showed that if you're 98 years old, 15% of us are going to have an operation. And if you're 80 years old, let's see where 80 is, almost 40% of us are going to have some sort of operation. Now, you have to define operation because a procedure and an operation may be differently. If you look at the supplement in the article, and when you're reading articles, maybe sometimes it pays to look at the supplements. The most common procedure done at the last 30 days of life was a percutaneous gastrostomy, a small bowel endoscopy, a left heart catheterization, and a temporary trach. They weren't doing big operations on patients. They were doing almost palliative things. I would argue maybe a percutaneous gastrostomy ain't the greatest operation, but if you're doing it to vent the stomach from a bowel obstruction, it's not really a procedure that is a morbid procedure. It actually could be palliative. A left heart catheterization can be done for chest pain. A temporary trach, a wound debridement. So we are all going to undergo some sort of procedure. I think our goal as surgeons, your goal as physicians, is to make sure that the procedures are appropriate for the patients. So in review, we reviewed the historic risk stratifications, old school and new school. We identified frailty and geriatric syndromes. I talked about it a lot, and I hope the three words you remember: dementia, delirium, frailty. And if you are frail, it could be timed up and go tests, mini mental scores, and mini cognition tests for dementia. We talked about specialized geriatric services and the way to follow them with real data. And we talked about palliative care. And if you can convince your hospital and your surgeons to get into the ACS geriatric verification program, go for it. So, is this a subspecialty? I don't know, pediatrics, thoracic, vascular, colorectal. They're all subspecialty now, and we have our quality care indicators for geriatrics. We have improved training now, and now there are even CMS standards. But if you ask any of the older surgeons or the older general surgeons, they'll tell you, we've been taking care of elderly patients all along. So I actually wrote an editorial once saying, it's not that we need a subspecialty. It's that we are a clinical community. And we are a bunch of people in the geriatric surgery world who have a combined or community interest in geriatric surgery. And this is myself, Mark, and Ronnie are the three authors of those textbooks I showed at the beginning of the talk. So from my mind, geriatric surgery has always been and will be a state of mind. It's a multidisciplinary game, and you have to get along with your consultants, and you have to respect them and respect, most importantly, your patient's wishes and the wishes of the family. And it's really something called a clinical community. And Peter Pronovost, who is an anesthesiologist and is now at the University of Cincinnati, and Mary Dixon Woods, who is a social scientist in London, in the UK, University of Leicester, put up this concept called a clinical community. A clinical community is a group of people who come together to achieve goals related to quality in healthcare. With a small facilitating team, like surgical leads or anesthesia leads or social scientists even, they can help coordinate and enable, and many participating clinical teams. They're made up of clinicians, managers, patients, administrators, and others who come together and create a community of action. They actually describe this for a different field, but it's exactly what geriatric surgery is. So that's what I think geriatric surgery is. It's a clinical community. The Armstrong Institute of Patient Safety is at Johns Hopkins, and it really is it's been a nice journey for me to come to this I wouldn't say conclusion, but come to this point where geriatric surgery really isn't just a concept. It's really being put into action by CMS, by the American College of Surgeons, and by other organizations. So thank you very much. I hope you learned something from this. And this is a picture of my 10 years. There's one missing. My 10 years as chair of surgery here at SUNY Downstate. It's a place that I always love, and I'm always happy to come back to. So thanks.